Thank you, sir. Thank you for the kind invitation and thank you for allowing us to present our data. What I'm going to talk about is Ivosidenib in cholangiocarcinoma, IDH1 mutated cholangiocarcinoma. But before I talk about our data, I'd just like to touch upon some of the facts, some of the aspects of cholangiocarcinoma that we already know about. The cholangiocarcinoma landscape in India, we know that about 6% of liver and intrahepatic malignancies are identified as cholangios, and about 2% of gallbladder is identified as cholangios, and that broadly translates to about 2,500, 3,000 patients, probably estimated in India. Based on anatomical classification, we know that about 80% are perihilar, and based on resectability, about 70% are actually unresectable, and about a third are resectable. When we talk about the genomic landscape of cholangiocarcinoma in India, we know that about 9% of these patients are mutated IDH1 positive, and this number is probably a little higher when we look at just the intrahepatic subtypes. And we also are well aware that among the different subtypes of biliary tract cancers, there is tremendous genetic heterogeneity. If you look at the IDH1 mutation status across the intrahepatic, gallbladder and extrahepatic, you see that there's a huge variability, and actually IDH1 is more common in intrahepatic. Talking about patient pathways in cholangiocarcinoma, usually there are two major pathways that patients present with. It could either be a cirrhotic patient who is actually being monitored under the care of a hepatologist who then refers on suspicion of intrahepatic cholangio. It could also happen that a patient with vague symptoms who is being treated at a general practitioner's practice then develops severe symptoms like jaundice and is referred to the emergency, or then is referred for evaluation to a hepatologist. Talking about genetic profiling, we know that if patients are resectable, genetic profiling could be done on the resected sample. But if patients aren't resectable, then at the time of systemic chemotherapy, at the first line is when is the right time probably to do a genomic profiling. And the ESMO guidelines actually have listed out the targetable and the not yet targetable mutations in cholangiocarcinoma. And IDH1 to FGFR, BRAF, NTRK, MSI high, HER2, these are the targetable mutations we have so far. But there are also a few mutations that are not yet targetable, such as the NRAS, the KRAS, TP53, ARID1A. And it so happens that ESMO in their guidelines actually have given a SCAT1A level recommendation for IDH1, which is probably not the case for any other mutation. NCCN guidelines recommend genetic testing at the time of diagnosis of unresectable or metastatic disease, and we know that even in India and globally, there are majorly three treatments available which are targeted therapies for cholangiocarcinoma. It's Ivosidenib for IDH1, Futibatinib and Pemigatinib for FGFR. And there are four major ways in which we could actually profile, or these are the different techniques that we could use to profile patients with cholangiocarcinoma. But what is usually recommended is a next generation sequencing. With this quick background, I'd like to move to IDH and our phase 3 clinical trial data for Ivosidenib in MIDH1 cholangiocarcinoma. Isocitrate dehydrogenase has multiple different variants. IDH1 is actually in the cytoplasm, whereas IDH2 and 3 is in the mitochondria. IDH1 and 2 are NADP dependent homodimers. IDH3 is actually an NADP dependent heterotetramer. And all these three isoforms of IDH actually convert isocitrate to alpha ketoglutarate. In a normal cell, as you can see in the diagram on the top, isocitrate, there's a normal IDH which converts isocitrate to alpha ketoglutarate. And alpha ketoglutarate is actually responsible for normal cell differentiation, leading to the development of a mature cell and of course subsequently normal cell death. But in a IDH1 mutated patient, you see that isocitrate conversion to alpha ketoglutarate doesn't happen. Instead, isocitrate is converted to 2-hydroxyglutarate, and 2-hydroxyglutarate is actually an oncometabolite which actually leads to abnormal methylation and epigenetic rewiring, leading to unchecked cell proliferation and cancer. And we believe this is the hypothesis behind the development of MIDH1 cholangios. IDH1 inhibitors are actually able to inhibit the formation of this 2-hydroxyglutarate, leading to normal alpha ketoglutarate formation, leading to normalization of the abnormal demethylation patterns, and causing a release of block differentiation and formation of normal cells. With this background, I'd like to segue into the phase 3 clinical trial for Ivosidenib in MIDH1 cholangiocarcinomas, the CLARITY study. And this is the first international phase 3 trial specifically targeting CCA patients with MIDH1. This was a multi-center randomized double-blind placebo-controlled phase 3 trial. Patients greater than 18 years of age with a histologically confirmed diagnosis of cholangio and a centrally confirmed IDH1 mutation status by NGS, with an ECOG PS of 0.1, patients who had been treated with 1 or 2 prior therapies, either a gem-based or a 5-FU-based, or even an adjuvant regimen, they were included. Lesions were measured by RECIST version 1.1, and patients had to have adequate organ function. Patients were pre-screened for an IDH1 mutation and then randomized in a 2:1 ratio to receive Ivosidenib 500 milligrams once daily orally in continuous 28-day cycles, and the other arm was the placebo-controlled arm. But based on discussions with patient associations, we had actually decided to permit crossover at the time of radiographic disease progression to give patients in the placebo arm the benefit of Ivo. The primary endpoint was progression-free survival by independent review committee, and the secondary endpoint was overall survival. In terms of baseline characteristics, we saw that about half the patients had been treated with 1 prior line of therapy, and about 40% of the patients had a ECOG PS of 0. Of course, given that this is MIDH1 cholangios, 90% of the patients were intrahepatic, and of course, most of the patients had metastatic disease. In terms of overall survival, we saw that Ivosidenib was able to demonstrate a median overall survival of 10.3 months. And when we looked at the unadjusted placebo arm, a median overall survival of 7.5 months was demonstrated. And given the fact that about 70 to 80% of the patients crossed over to placebo to the Ivo arm, we had to actually adjust for this crossover. And we then deployed a US FDA approved RPSFT adjustment, which resulted in a median overall survival of 5 months in the placebo arm. And this difference between the Ivo arm of 10.3 versus 5.1 was actually statistically significant with a hazard ratio of 0.49. We also looked at subgroups of patients and compared, or rather, we looked at OS in these different subgroups. We looked at subgroup of patients who were treated with prior 1 line of therapy, and we also looked at a subgroup of patients who were treated with prior more than 1 line of therapy or 2 lines of therapy, and we saw that probably there's a trend towards a better OS in the patients who are treated in the 2nd line with Ivo as opposed to patients who are treated in later lines. The OS in this group of patients was 14.8. We then looked at progression-free survival, and we saw that in terms of PFS, a median PFS of 2.7 months was demonstrated with Ivosidenib versus a median PFS of 1.4 months in the placebo arm. And you see that in the initial few months, or rather in the initial 2 months, you see a significant dip, after which there is a clear separation between the curves, especially after the median. Ivosidenib was able to demonstrate a 6-month PFS rate of 32% and a 12-month PFS rate of 22%. We also looked at PFS between subgroups, and we see that there was a consistent benefit across different subgroups in terms of PFS with Ivosidenib. And we also looked at PFS within subgroups. We looked at PFS in patients treated with prior line of therapy equal to 1, where we saw that Ivosidenib demonstrates a PFS of about 3 months. And we also looked at PFS in the subgroup of patients treated with more than one line of therapy, that is Ivo in third line. And we see that in this subgroup of patients, Ivo demonstrated a PFS of about 2 months. Duration of treatment with Ivo, even after crossover from the placebo arm, was equivalent to the treatment arm, around 3 months. And what was also striking was the safety profile of Ivosidenib, where we see that it was generally well managed. Most common grade more than or equal to 3 treatment emergent adverse events included ascites, anemia, and an increase in bilirubin. But what I found striking was the fact that treatment emergent adverse events leading to discontinuation were actually more common in the placebo group than in the Ivo group. We also had a subgroup of patients who were able to continue on treatment beyond 1 year. This includes patients from both our phase 1 study as well as the phase 3 Clarity trial. And we see that in these two studies, patients who were treated more than 1 year obviously had an OS which is quite high, around 38 months, and a PFS of about 15 to 16 months. But what was most important was that almost all the patients experienced a tumor shrinkage. And this was not the case in the overall analysis, where only about 2% of patients, the ORR rate was just 2%. Disease control rate was about 50%. We see the picture changing on long-term treatment. We also had a small real-world evidence on Ivo, about 11 patients, and we, in this RWE, saw that the PFS was actually a little higher than the phase 3 clinical trial. PFS was about 4.4 months, and the OS was about 15 months, which is a little higher than in the clinical trial, probably hinting at the fact that in the real world, you can actually get better outcomes. There's also a recent American real-world analysis of about 1,000 patients with cholangios, out of which 83 are IDH positive. And here in the Kaplan-Meier curve towards the bottom, we see that there are about 83 patients, out of which 83 patients who are IDH positive CCA, 40 are treated with Ivo, and 33 are not treated with Ivo. And you see that there's a stark difference in overall survival outcomes when you compare these two groups. The IDH positive patients treated with Ivo demonstrated a median OS of 25 months versus 8.7 months. Lastly, I'd like to touch upon the guidelines from ESMO, which are recently updated, which include Ivo with a 1A recommendation, and also the NCCN guidelines, which actually include Ivosidenib with a category 1 recommendation. Thank you, and I can take any questions if there are any. So.